So what we're going to do now is kind of switch things up a little bit. We're going to give Mariah a little bit of a break here, which I think is an important thing to do. And some of the things that we're going to fold into Heather's segment. Does everyone know Heather? I don't think necessarily everyone does, but we're very, very lucky at the plan to have our own specialized respiratory therapist. Yeah. Not everybody is so lucky, and folks who do aren't as lucky to have somebody like Heather, who can be very candid and direct and really practical with knowledge of all these different things like the inhalers, DME equipment. So there's a lot of good stuff she's going to be able to help us understand here today, and be very hands-on is Heather's style, right?
It is.
I think so. Oh, you mic beautifully. Wow, we can hear you great.
Works really well.
So let's move forward. If everyone's ready, please welcome our good friend Heather.
Hi, everyone. Everybody lower your expectations, please. So the first thing we're going to do is finish up with the inhaler presentation. So we had a lot of talking. That's helpful, but I think that the reason that people don't get their inhaler education in the way that we would like is because we don't, as a community, feel comfortable teaching the inhaler because they change so frequently. Even as a respiratory therapist, I have to really work to keep up with what the inhalers are and how they work because they're constantly changing. You all have inhalers on your table there. We're going to show some videos about how to use those, and then we're going to actually go through them together. So we'll watch the videos first, and then we'll do that. Okay, so it looks like everybody has that one. A couple of things I would point out about that. You know, there's the counter. This one has a really nice size counter on it, which is not always the case with inhalers. But that counter is not always obvious to the patient, right? So even though we think that obviously there's a counter there, they're keeping up with it, that may not be the case. You know, so when you have a patient demonstrate this for you, the things that I would watch for are, you know, that they're opening with their new dose, that their mouthpiece is clean. You know, some people aren't necessarily paying attention to that, so we want to make sure that that's clean, and that they're not covering these air holes. I think that's going to be an easy thing for people to accidentally do, and so keeping an eye on that. So you can easily put your thumb over that when you're holding it. Yeah, and then usually you are going to rinse after you use this. But, okay, so we can show the next one.
And just to remind you all, so this inhaler is available in Incrus. It's also available in Noro, and it's also available in Trelegy. So the device is going to look exactly the same for the member as you move up the intensity of their therapy for COPD. So, you know, we don't have to retrain them on a new inhaler every time. We can increase the number of meds that are in that device, and they really won't even know the difference. They use it the exact same way.
One of the things I want to point out before we go any farther is you probably have heard us mention, or people mention spacers with their inhalers throughout time, and none of the inhalers we're showing you right now should be used with a spacer, which is different, right? And I think that that's kind of the trend, that we're getting away from adding another device for people to have with them when they take their inhalers, because most people won't use the spacer anyway. So this is none of these inhalers are designed. These won't work with a spacer, so just keep that in mind. So the Respimat is the next one that we're going to do. Everybody has this one. It might still be in a box. Yeah. I'll let everybody kind of get what, if they can get access to it, I'll let you get it out before I start the video. And here is an extra one. Is there somebody sitting here?
Nope. But it's not that.
Hmm?
It's not that.
Oh, which one is the right one?
Yeah, we don't have enough.
Okay. All right, so we can go ahead and start that video, and then we'll talk about it afterwards. Does everybody want to catch up to where we are right now before we keep going? Yeah. Okay, I can feel it. So there's a canister. Why don't I use my example?
Now you know why we focus on smoking cessation.
Right. And why we prefer the Ellipta over this one. So this is what you probably took out of your package, right? And so here's the medication, vital, that we point this out to patients, because I can't tell you the number of people who try to take it with no medication in it because they don't know what this is for. And so I want everybody to get to the point that they've got their canister in the container and that they've actually used it and pressed down on the table to get it in place. Yeah, you're good.
So user-friendly.
You're good to go. It is, right? And it's, you know, the intent, but I don't know what the intent was. I think the intent was when they went from the combi vent. We used to see this combi vent in just a regular inhaler, right? Like, and we had to use a spacer with it. And I think that this was supposed to be a better choice, you know, and make it so that you don't have to have a spacer, and it's supposed to be more, you know, easily used by the patient. But I'm not sure that that was achieved.
So they had to remove the vehicle to prevent ozone layer destruction. So this was the best that they could come up with.
Okay.
So that was a federal regulation to remove all those propellants. And this is also how tiotropium comes now. So, which is why we don't have the Spiriva discus device. They're not promoting that anymore. They want everybody moving to this format for Spiriva, just so you know, which is why, again, we're not preferring it anymore.
So is everybody good where we are right now? Are we all at the same place? No?
After you get the cartridge loaded. I missed the part between
We're
that
going back.
and putting it back
Maybe
in.
we could back up just a little bit if we can. I don't know. Okay, any immediate questions about that? I'm going to talk about it a bit.
You have to turn it each time.
Yes. So to activate a new dose, do you have to turn it each time was the question? And yes, you do. You have to turn, for each dose, there has to be one click. So these are a few things that I find with this. People will, when they're trying to open the mouthpiece, they will press the release button but too soon because it's just right there. This gray button. So after it's been primed, right, they are opening this, and this button here can get hit before they actually take their dose. Okay, they have to redo it if that happens. It's not the end of the world, but they have to turn it again and start over the process. They can't finish that dose once it's started. There's a counter on the side that she pointed out. And I find that people usually pay attention to that more so than the number, but still, you know, paying close attention to when it gets down into the red. A lot of people use this as their rescue inhaler. So it will go, you know, pretty quickly. And it may or may not have been intended to be used as a rescue inhaler, but this is what a lot of people will use because they do get immediate benefit from it. So keeping that in mind.
Which medication would this be?
So this,
Spiriva? Sorry.
so this one is CombiVent.
This, okay.
It can be, but the mechanism can be used for Spiriva or CombiVent.
Okay.
Those are the only two, right? Okay. Does anybody else have any questions? Yes.
It seemed like the demonstrator said you have to prime it by doing that a total of 4 times, because she did it once and said do it 3 more. Is that true?
I think it's 3 total. And the reason, that's only with a new inhaler, right? So that would be a really important thing to go over with a member whenever you're prescribing it for the first time, and if you're a pharmacist, each time you give it out to a patient, because they have to do that at the beginning of the new inhaler, but not every time they use it.
Right.
Okay? Yeah.
It's more of a, I guess, tip than a question. A lot of times when I've started patients on these, I always, if they're kind of unsure how to use it, because if you have a demo, it's already loaded, you can't really show them that process. I always tell them to make sure they tell the pharmacy to do it for them the first time and don't leave the pharmacy until they've showed them how to use it.
That's a great suggestion, because it's harder to get in than you think, and people don't like feeling like they're almost breaking a piece of you know, this costs money. They know it costs money. They don't know how much maybe, but they know it's expensive. And, you know, to force it down like that actually might feel like you might be doing it wrong. I can tell you this as we continue to go through. Almost everybody has access to YouTube now. I don't know how that has happened. Like, it doesn't matter if you have a house, but you have access to YouTube almost always. And so show people these videos, like pick some videos that your clinic likes, pick ones that they're short, and send them to the patient's phone. If you guys have a way to do that, like have a way to just, text it to their phone. Seems really simple, but people will watch these videos. I mean, you guys have gotten a lot from these videos, hopefully, so far, and you understand all this. This is our world. So having a way to repeatedly see this demonstration is really valuable for patients. Yeah?
Just one comment that you made. They talked, is this on? Yeah. Okay. They just talked about when it gets to the red zone that they have 7 days left, but that looks like 30 inhalations, and it's a once-a-day inhalation. It doesn't make sense to me.
Well, this can come in different frequencies because this can have different medications in it. So if it's COMBIVent, people will be taking it more often than once a day. So it just depends on what the frequency is.
But for this, if it was just for the Spiriva Respimat, which is once a day, that would be 30 days left. When
Correct.
It is 30. Okay,
right.
Thank you.
Just a clarification, the Spiriva is the tiotropium part, in that if you look at the patients that will need a Respimat in Class C, it's a combination therapy, Stoecklin, which is Spiriva plus a long-acting beta agonist. I mean, I know that we're talking about alphabet soup again, but for our purposes, the Respimat for Spiriva alone is not part of the COPD treatment pathway for CareOregon. It's the Stoecklin, which is their LABA-LAMA combo, if you look at your Group C there.
Okay, we can show the next one. So a spacer is going to be valuable for your patients that are using Provenal and any form of albuterol as a rescue inhaler. You're still going to see that form of inhaler for rescue inhalers, and you're still going to see people that need to use spacers with that. So we are going to talk about that a little bit more, but that was, we can do the one for the discus. I think that's the last one. And so this one is for this inhaler. Okay, any questions about that one? This is probably one you've seen more often than others. Does anybody have any questions about inhaler technique or any thoughts about how that goes in the clinic? I think it's a lot to, it can feel like a lot to add to what you're already having to talk about when a patient comes in. So creating that normalcy for this in your clinic is really important. Having some way of identifying which patients you have that are on inhalers so that you know before they get there what they're supposed to be doing, and not solely relying on the medical assistant for that is probably, important because they, the patient has a regime that they're supposed to be doing. What I see happening when I'm in clinics, when I go to appointments with patients is someone's going through a list and saying, and it's not because of fault, it's because of time constraints, and the patient probably didn't bring their meds. So that's the reason it happens like this. But they go through the list and they say, are you taking your Advair? And the patient will say, yes, and they'll check it off. Are you taking your albuterol? Yes, and they'll check it off. When we should be really deep diving into each one of those things, right? How often are you taking it? Show me how you take it. Are there any problems with it? Is there anything you don't like about it? And we should be somehow recording that information so that we can refer back to it when they come back. And it's also helpful to know how people take their inhalers and have that documented somewhere so that when that member calls your clinic with problems and they're saying, I don't have, my inhaler's not working, if you already know that that patient has had problems with technique in the past, then you don't have to spend a lot of time trying to teach them technique over the phone. It's probably not going to work. If you've done a lot of teaching in person and they still don't really understand their inhalers well, that may not be the place to spend your time when you're triaging. So having that information at hand is helpful. So that is it for the inhalers for right now. Does anybody have any questions? Okay, so we're going to go on to more important things, less important things, depending on how you look at it.